It is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Come on, shake your body, baby, do that conga. No, you can't control yourself any longer. Come on, shake your body, baby, do that conga. No, you can't control yourself any longer. Come on, shake your body, baby, do that conga. No, you can't control yourself any longer. Feel the rhythm of the music getting stronger. Don't you fight it till you gotta do that conga beat.
Wow, that was Gloria Estefan, and she really rocks, and we're going to really rock today too because we have our sound back. There was a famous American movie, maybe 15, 20 years ago. It was called Poltergeist, about a little girl that sees ghosts inside of her television. And the famous line from that movie is, "We're back!" And that's exactly what we are. We're back. I know we have sound. I know everybody can hear Gloria. I know everybody could hear me. In fact, I'm also hearing a little bit too much sound I may have to mute somebody. I know we're hearing a little bit of background stuff, so I don't know. I'll have to look to see who's unmuted, and maybe I'll just mute them. So let's go to our attendee list. And by the way, we're all here. Nobody has given up on the course because of the technical problem. You're all back. In fact, you're back in bigger numbers than you ever were before. I know we also hear a little bit of noise in the background. It's not as bad as it was on Saturday, but we may have to bear with it. If you can't bear with it, then you know what number to call instead. But I think you could all hear me pretty well, right? Can you all hear me pretty well is the question. Do you also hear the little noise in the background by any chance? Okay, I don't know, but that's nobody there. It was here on Saturday, and it's not as bad as it was before, so I guess we'll just have to live with it. You know, when I was a kid, and for some miraculous reason, we got an unexpected day off of school, we were about as happy as could be. Now that I'm grown up, and I'm on the other end of the school desk, I wasn't too happy. In fact, I could tell a lot of you were not too happy either. But we're back in full force. Nobody's lost, and we're going to have a great day today. I know you can already hear me. All you got to do now for the second part of the test is tell me what you see on your screen. By the way, the noise just stopped completely. Okay, we all see the kitty, and this is who we were supposed to see on Tuesday, but Tuesday never happened, so that's why we have built in a lot of buffers into our course. If we have to extend it an extra day in May or an extra day in December, we can do that. We're going to be finished probably by mid or late May, even if we have another technical flop, which, by the way, has never happened in 4 years, so that's good. Any more announcements? Yeah. Today is Thursday, September 20th. This is session number 5. We're going to be dealing with these two topics here today, regeneration and healing. We're in Chicago. It's 9 a.m. and this is your free global online medical school pathology course. Today we're going to have a lecture in the lab, and here's the lecture, first PowerPoint. We can make it even bigger. And this is going to be our lab over here. After we do the lecture on regeneration and healing, we're going to take about 8 slides in the second half and talk about them, showing the changes that we have talked about in lecture. Although, you know, we're not supposed to use the word lecture. It's a no-no word these days. We're supposed to say discussion or something like that. Let me tell you about the personality of today's topic. Okay, I always have to be honest, and I usually say this is my favorite chapter, this is my favorite chapter, this is my favorite. In all honesty, it's a nice chapter, but it's not my favorite one. And the reason why it's not my favorite one is it flows as much as I could make it flow, but then there's a lot of material in here which unfortunately I'm just going to have to shovel at you again. You're going to have to look at all of the section we talk about on growth factors, and you're just going to have to kind of memorize it. I hate to use that word. Because we just can't fit it into the epic or the saga or what we called with inflammation the Cecil B. DeMille epic. So it'll be a good one. But the nice thing about this one is that the other parts are very logical, very graphic, and it will lead us in next session to absolutely my favorite topic in the first half of pathology course called hemodynamics. So it seems like we're learning a lot of basic science again in these first 3 chapters, but when we get into the 4th one, we'll be talking about like real diseases, and we're going to bring the patients into the pathology class now. Okay, we might as well open it up and start it then. Here's our maximized screen. Here's our topic. And if you remember, we spend a lot of time, in fact, the last couple of days, even the beginning portion is talking about inflammation. If you remember, we said that 3 possible things that could happen with inflammation or acute inflammation is number 1, completely return to normal. Number 2, go into chronic inflammation. And number 3, form scars. Well, today we're going to talk about how that big mess, that war in the Cecil B. DeMille movie with all the dead people in the field, are returning back to normal. That's called healing. Also, we're going to be talking about the process by which this acute inflammatory process goes into this concept called fibrosis as well. So the three things we'll be dealing with today are regeneration, something called organization or neovascularization, and then finally at the third end of the scale, we're talking about fibrosis. So here's what we're going to learn about today. A little bit of normal physiology on cell proliferation and growth. Most of you may have had even this deeper in cell biology. We're going to talk about the basic factors of regeneration, how tissues come back to normal. And we're going to understand the relationships between the cells that are in this process and their extracellular matrix. And then there's a topic here that has many, many, many names. Probably the very best name is called ingrowth of new blood vessels, but it's also called angiogenesis. Some people call it granulation. Some people call it neovascularization. We're going to talk about the growth factors, or GFs, of which there are many and a growing number every day, influence this whole process. And finally, the end stage of many or probably all inflammatory processes when there's not complete regeneration or chronic inflammation. There's a concept of fibrosis or scarring, proliferation of fibroblasts. So in the second part of the epic today, endothelial cells are the main players, and in the final part, fibroblasts are the main players. We're going to talk about something that's always emphasized on the boards and also clinically, the so-called first and second intention healing. It's extremely simple to understand. Okay, here's our definitions. What is regeneration? Regeneration is growth of cells to replace lost tissues during the after the destructive inflammatory process. Okay, now healing is a little bit different. It's a reparative tissue response to a wound, inflammation, or necrosis. Remember, all those things that cause acute inflammation, and it often leads to fibrosis. And sometimes it doesn't lead to fibrosis at all. And whether it leads to fibrosis or not is dependent upon the degree or the amount of extracellular matrix that has been disrupted or destroyed during the inflammatory process. And then finally, I put two things on here which are identical. It's called granulation tissue, or the ingrowth of new blood vessels, endothelial cells, neovascularization. It's also called, quotes, organizing inflammation. So when you hear the term organizing inflammation, it's already talking about the reparative or regenerative process in which the destructive acute inflammatory battle site is preparing to bring in new blood vessels to return everything back to normal. Now, regeneration is simply replacement of lost structures, lost cells. And it's completely dependent on the type of normal turnover the original tissue has. So if you have tissue that normally turns over really, really fast, like epithelial cells or bone marrow, for example, it also regenerates really fast. If you have tissue that does not turn over really fast, let's say kidney or just about any other thing, it would be slower. And of course, cells which are incapable of dividing or multiplying, I guess both dividing and multiplying means the same thing in this context. Cells that can't divide, perhaps they have no spindle apparatus, like skeletal muscle cells, like cardiac muscle cells, like mature neurons. They do not multiply. They cannot undergo mitosis. Then, of course, there's no regeneration there, which is why it's so difficult for central nervous system neurons and skeletal muscle cells to regenerate. Their precursors can divide, but the mature cells can't. And you have to remember there's also a concept called compensatory growth, which is not exactly the same as regeneration. And it means, for example, if you gave your cousin a kidney as a present, your kidney that was left behind in you will become bigger. Another really good example is when you do CT scanning or nuclear medicine scanning and you're looking at organs. Very often, if there's been a large portion of that organ that is gone, for example, part of a liver, maybe they did a partial hepatectomy, that will grow back amazingly quick. I'm talking about months, perhaps even years, but very often if you take off half of a 1,500 gram liver, it'll be 1,500 grams again in, let's say, 6 to 12 to 2 years, let's say. Okay, healing now, repair. It needs a wound and an inflammatory process or anything that causes it to begin with, because you can't heal if there's nothing that's been damaged, right? Now, many diseases that we'll be talking about this year are actually the result of healing, and the most notorious of that is atherosclerosis, because when we talk about what is atherosclerosis, what's causing it, it's basically regarded these days as a reparative process to damaged endothelium. And what exactly damages that endothelium is not always clear. Now, healing often ends with a scar, and sometimes it doesn't. And if it doesn't, it means not much of the extracellular matrix has been disrupted. Like in a clean surgical excision, for example. When it ends with a huge scar, it means a lot of tissue has been gouged out. It means that a lot of the extracellular matrix has been disrupted. So scarring is the same as fibrosis, and if you remember, scarring or fibrosis was one of the 3 possible outcomes of acute inflammation. We said that the whole process goes on in this mysterious concept called the connective tissue scaffold. Okay, so all the regenerative cells, whether they be epithelial cells or endothelial cells of blood vessels or fibroblasts, they require a connective tissue matrix or scaffold in which to do their process. So that's where it takes place. And we said also fibrosis is in direct proportion to the amount of damage of the ECM. Now, this is a very logical thing. I believe this is from Robbins, and I like this diagram a lot because you really don't need to see the diagram. You know that if you have a baseline cell population in your body, anywhere, any type of cell, it can only do 3 things. It could just multiply, make another exact cell, or it could do this mysterious concept that we call differentiation. It means it divides, it multiplies, but in the process of doing it, it changes a little bit to become more specialized, either anatomically or physiologically. And of course, we all know the other thing that could happen, that could die. If it dies because of its normal time, it's called apoptosis. It might also die because of a pathologic process. We would probably more term necrosis. In these baseline populations of cells, wherever they are in your body, they are constantly being proliferated from lesser differentiated cells. And the lesser the differentiation is, the more likely it is to be a stem cell. Theoretically, a stem cell is the mother of all cells. A stem cell concept is like a fertilized ovum. It can and will eventually differentiate into every possible cell in the body. So those are the 3 things your cells could do. And this concept of differentiation actually is something I've been thinking about almost every day of my life, and it's just miraculous how a fertilized ovum can become every possible of your, several trillion cells in your body. So, here we go again. Here your cell population fates. Proliferation, differentiation, and apoptosis. Nothing else can happen to a cell, only these 3 things. And of course, proliferation is often determined by hormones, especially the steroid hormones, which generally act upon the nucleus, which trigger it off into mechanisms which will tell it to divide, including things like EPO and CSF, okay? And And of course, differentiation is regarded as a unidirectional process. In other words, when a cell differentiates, it becomes more specialized, not less specialized. It's unidirectional. It may come from less specialized cells, stem-like cells, but when it differentiates, it always becomes more differentiated. There was something else I wanted to say about that, but you know, as a pathologist, this concept of differentiation is something you deal with every day, and sometimes you see tumors arising from cells, and you say, oh my God, this tumor is less differentiated than the mature cells that it came from. So is that de-differentiation? Is there something called de-differentiation? Well, that's a nice little theory, but in fact, the actuality is that when you see a undifferentiated tumor, it is not de-differentiated or differentiated in the opposite direction. It usually means it arose from cells that were rather undifferentiated to begin with. Okay? So primitive or undifferentiated tumors do not arise from differentiated ones. They arise from the more primitive stem-like cells in the population. Here's another concept to remember, not just from histology, but also for diseases in general. And we're going to see this over and over again, and this is a good place to mention it. You remember from embryology your 3 basic germ layers, you know, and of course these relatively undifferentiated, unspecialized germ layers arise from less differentiated ones, and then they basically differentiate into everything in your body. You know, the ectoderm is, let's say, we'll call that skin. Mesoderm is basically all your connective tissue, and endoderm is the epithelium of your GI and respiratory tract. So things that happen to cells from every one of these 3 layers are likely to happen to other cells in those layers. Let me give you an example for, let's say, transitional epithelium. It could be in the pelvis of the kidney, it could be in the ureter, it could be in the bladder, but it's all derived, those transitional cells are all derived from one layer of cells. And therefore, diseases that affect, for example, the transitional epithelium of the renal pelvis, almost exactly the same kind of inflammatory and neoplastic diseases will cause the same types of changes lower down in the bladder. And also remember, in the concept of general tumor degeneration, or tumor biology, we'll say, the mesoderm, which is a connective tissue which gives rise to all your connective tissue elements, that's going to be giving rise to tumors that are mesodermally or mesenchymal in origin. You know, like in the malignant counterparts would be sarcomas. Whereas tumors of ectoderm and endoderm, which are more likely to give rise to epithelial type structures, not much connective tissue, will give rise to epithelial tumors, like adenomas if they're benign, or carcinomas if they're malignant, and adenocarcinomas if they're glandular. Here's another basic concept, and I believe this one is extremely too easy for you, because I know you've probably all had this in great detail, but we talk about proliferation and multiplication of cells now that either come into an inflammatory process or replace other cells. You have to remember the cell cycle. Now, even as low as, 3rd grade, we probably saw something called mitosis, which are just these 4 little phases of the cell cycle. Prophase, metaphase, anaphase, telophase. The chromosomes getting thicker and then lining up and then splitting apart. The cytokinesis is actually the division of the cytoplasmic mass that surrounds it. That's still only a small part of the cell cycle. Once you have your so-called new cell, it grows, and that's called G1. Or you can also call it pre-synthetic, because a big phase now in the interphase is called the synthetic phase, in which your growth and DNA synthesis occurs. And of course, after that, you can have something called post-synthetic, I guess. It's also called G2. And once again, that's making an arrangement for your cell division again. So you have to remember, we talk about a cell, it's never totally quiescent. It's always in one of these phases. And depending on what kind of cell it is, it's going to be in one phase longer than other. For example, a cell that's very labile might be in S phase much longer than a cell that generally doesn't divide too much. So there's your cell cycle again. G0 I want to mention as the phase that immediately follows the mitosis, that immediately follows the cytokinesis of the mitotic phase, the very first stage in interphase. And then you have your pre-synthetic G1, then you have your S phase, and remember, cells which have continuous turnover have a longer S phase. And very often you can actually measure the S phase of cells, and especially tumor cells. And if a tumor cell has a long S phase, it's not good prognostically, because it means it's being more active, it's being less quiescence. So the quiescence of the cell is inversely proportional to the S phase. And of course, G2 again is getting ready for mitosis, and there you go. PMAT, prophase, metaphase, anaphase, telophase, and then finally your cell splitting apart. Keep that in mind. So practically speaking, we talk about cells which are either going to replace other cells or develop neoplasms. You basically have three groups. And you have the cells in your body, and you know what they are, that turn over quickly. Like bone marrow turns over incredibly quickly. You know, the lifespan of a mature neutrophil is just a few days. The lifespan of the cells which arise from the crypts of Lieberkühn are generally also a few days. This is very, very labile tissue, right? Now, there's also cells which divide, but they don't actively divide all the time. And a very good example of that is liver and kidney. And even though the liver is often cited as the most regenerative of all organs, the actual time that a cell takes in the interphase is relatively long, just like kidney. You know, these cells are not multiplying every day like these are. And of course, there are the non-mitotic cells at the opposite end of the spectrum, like neurons. Mature neurons don't multiply. Mature striated muscle doesn't multiply. So if you do an electron microgram of a neuron or a striated muscle cell, and you see that there is no spindle apparatus, doesn't have the capacity to undergo mitosis. That's why regeneration of these tissues is very, very, very problematic. And I know you'll read articles every day that talk about research going on to replace brain and muscle cells. I would challenge you to give me the name of one person you ever heard of that had normal muscle, you know, replaced, you know, by this so-called gene type therapy. Okay, so let's go back now to the mother of all differentiated cells. We'll call them stem cells generically. And, you know, the word stem is a very, very politically loaded word. So that's why sometimes they're called totipotential, because they are cells which have the capability of multiplying or differentiating into anything, into all three germ layers, into any cell. Sometimes they're called omnipotential. Sometimes if they're not totipotential or omnipotential, but they're almost omnipotential, they may call them pluripotential. So there's various degrees of stem. But let's just say a stem cell is a cell which could generally give rise to any type of tissue that it could possibly do. And of course, the concept of all stem cells is a fertilized zygote, isn't it? That's kind of like the mother of all stem cells. Even though cells in the blastocyst, I am told, are also can give rise to anything. They can be both embryonic and adult, and the embryonic concept is very easy to understand. Fertilized zygote, a blastocyst, differentiation to your germ layers, and all these crazy things which you may have learned about in embryology and are not really that important for general medicine, but are extremely important for understanding tumor development and pathology. But as an adult, you have stem cells also. You have stem cells just about everywhere. And normally they're not very populous. Normally you don't see them in big numbers, but they are there, and they are there to replace epithelial cells and marrow cells, and they're in small numbers. They're even theoretically sometimes in the peripheral blood. So here, let's look at some of the adult stem cells. In the marrow, in the old days, we called blastic-looking cells hemocytoblasts. I notice they don't use that term now. They may call them hematopoietic stem cells, and these are mesodermally derived cells, and they could give rise to any type of blood cell, whether it's red, white, pink, platelets, or anything. And they may not look any different than any other blast cell, and they can't really be differentiated from some of the real big precursors of cells of the three cell lines, platelets, red cells, and white cells. But they're there. And actually, in very, very small numbers, they can even get out into the peripheral blood. And they can even be harvested. And once they're harvested, they could be grown. And then once they're grown, they could be put back into the patient. So you could take stem cells from a cancer patient, massively irradiate his bone marrow, and then put the stem cells back. And sometimes that works. In some of the growing tissues like hair follicles, and in the crypts of the GI tract, and even here in the limbus of the cornea, you'll never learn about this in histology. You'll learn that there are certain types of cells, and here are their names. But there are totally potential cells. They often call them regenerative cells or stem cells or progenitor cells, and they can basically give rise to all the epithelium or connective tissue that's needed to repopulate that area. Okay, and this is a really good example. Here's your pluripotent stromal cell. Okay, because it's stroma, the things that it's going to give rise to are things that are connective tissue in origin. So that's why it's not called omnipotent, because if it was omnipotent, it could give rise to both stromal as well as epithelial cells. But here are pluripotential stromal cell. Now look at, they differentiate into things like muscle cells, fat cells, osteoblasts, chondroblasts, endothelial cells. These are all marrow stromal cells. These are all things that are in the marrow. They can also give rise to the marrow cells as well. So what is it that makes this undifferentiated cell become more differentiated? Well, one of the big things is this concept we're going to be throwing at you very soon called growth factors. Okay, for example, VEGF, vascular endothelial growth factor, fibroblastic growth factor. So the GFs are, I guess you would probably call them differentiation agents. That's one of the big things that do this. Now, and that can be help you better understand from embryology why totally omnipotential groups of cells like a blastocyst can then differentiate into your germ layers, and then your germ layers can differentiate into both bone marrow blood cells as well as connective tissue cells, and your endoderm gives rise to things like epithelial cells, GI tract, and ectoderm, keratinocytes, but also some connective tissue cells which support them as well. So when you look at this little tree here and you think, well, how does it or why does it go from here to here? Think of GF, think of growth factors, and that's basically what we'll be talking about now for about 10 minutes. And this is the part of the thing I don't like. But I shouldn't have said that. I'm going to ask you now if everybody's been hearing me okay. We still have no sound problems. Has everybody been able to hear everything without any more jabber or noise? And the second question is, sometimes when I'm really excited to be back, I talk a little too fast. Be honest, am I talking too fast? Okay, nobody thinks I'm talking too fast. That's very nice to know. So we're still going to be rocking and rolling then. We said that the big function of growth factors is differentiation, this mysterious concept of how one cell can turn into another cell. Part of that is angiogenesis too. And remember, angiogenesis, or the formation of new blood vessels, is the single biggest factor in the reparative or regenerative phases following acute inflammation or any other tissue disruption. Very often, they can cause contractility and locomotion of cells, not just muscle cells. But remember, when you repair, you have to bring these cells into the area of battle. Well, they don't get there by themselves. They actually have to move in there. And that's what some of the growth factors do in generally. Generally, the growth factors are all polypeptides. They might be as little as 9 or perhaps a lot more, just a few amino acids in length in general, like many of the hormones. And except unlike the hormones, they're having their effect paracrine or locally rather than endocrine or systemically through the bloodstream. And they also can be described as being like cytokines because they're made from cells, and some of the growth factors are cytokines and some of the cytokines are growth factors, but they're not exactly identical in term. So let's talk about the different GFs. Okay, you're going to have to suffer through this because we're going to go into we're going to go into 8 things here, and they're not going to fit very, very nicely into this whole saga of inflammation, organization, and fibrosis. They occur with the various cells involved at various levels. Sometimes they're named in order of where they came from. Sometimes they're named in order of where they go to, and sometimes the ones that they discovered work on epithelial cells, they then find out that they also work on connective tissue and vice versa. But nevertheless, here are the names. E for epidermal growth factor, so EGF. T for transforming. Often there's another type of growth factor discovered after the original one is, so that's why they're often called alpha and beta. Hepatocyte growth factor, HGF, and at first it was discovered that it worked great on hepatocytes. Then they found out that it worked on other types of cells, but they couldn't change the name at that point. Probably the single biggest, most important growth factor in the reparative process, the one that is the key player in determining the ingrowth and differentiation of the new endothelial cells to become blood vessels, is called vascular endothelial growth factor, or VEGF. Similar to that is another one that's also very important. I guess all these are important, derived from platelets. So that one, so if somebody asked you ever on an exam, where does platelet-derived growth factor come from? You know, that's going to be like the easiest question in the world. Or fibroblast growth factor. In this case, you don't know whether it comes from fibroblasts or goes to them. There's another one similar to epidermal called keratinocyte. And by the way, most of these things a long time ago were discovered, and by now, I don't know the list, but most of these things can be genetically engineered now to be produced in great numbers. And you can imagine what the effect on certain diseases might be by the infusion of vascular endothelial growth factor. So the desire, the business to synthetically or genetically engineer these in great amounts is very important. Now we talked about the cytokines. In a way, they're growth factors also because they determine differentiation. Or remember TNF, tissue necrosis factor, alpha and beta. Those are cytokines, but they're also growth factors. The interleukins, one of which is the main one, and even the interferons. These are all regarded as having growth factor properties. We're going to have to say a few words about each one now. So if you do have a piece of paper or you want to scribble on your notepad or whatever you do, I would suggest you start doing that right now. It's going to be kind of a memory game for the next 8 or so PowerPoints. That's generally what they look like. That's a polypeptide. And you can see they're not very long like proteins. They may be just a few amino acids long. Probably no more than hundreds, I would guess. Where do the GFs come from? Well, they come from cells. And sometimes you know where they come from by their name, like platelet-derived growth factor. Duh, that's the answer. But lymphocyte is a great place, and it's more likely to come from the T cells rather than the B cells. The B cells are generally antibody-oriented cells in one way or another. The T cells are more likely to secrete, the cytokines and a lot of the growth factors. Macrophages are a very, very big place to come from. Endothelial cells, some come from the endothelial cells, but it's more likely that some of these growth factors will have an effect on the endothelial cells, because the endothelial cells have to come in and do their job. Otherwise, there would be no healing. Fibroblasts are important, especially the main players after, but overlapping with the endothelial cells, because fibrosis is basically the endpoint of this whole process, if there is very much, and if the extracellular matrix is damaged very much. Keratinocytes, or regrowth of epithelial cells. You have a skin ulcer, you have a tick bite, you have a chigger bite, and you got some ulceration of the skin. Well, the local process by which those keratinocytes repopulate are totally controlled by growth factors. And remember, the mesenchymal cells in general, any connective tissue cell, bone cartilage, fibroblasts could be regarded as sources or targets of growth factors. And of course, smooth muscle cells, very, very, very important as well. Remember, even though the striated cells do not multiply, the smooth muscle cells can multiply like crazy. Look at a woman's uterus. It might weigh, 50 grams non-gravid and, 500 grams gravid. That's a lot of multiplication of smooth muscle cells. So here's the first one, EGF, epidermal growth factor. Well, in this case, you know that the epidermis is something it affects because it affects on keratinocytes. It not only to divide, but to migrate. So something that causes a keratinocyte to divide, for example, would be called mitogenic, right? It's made in a lot of places. Platelets are probably the single biggest places. Macrophages make almost all of the growth factors in one way or another. It also could be present in secretions like saliva, milk. And not only do they affect epidermis, which was discovered originally, but also affects fibroblasts. So EGF, even though it's called epidermal, it also affects the tissue underneath it, the fibroblasts, as important in the role of granulation tissue, because not only are you bringing your endothelial cells, but you're also bringing fibroblasts during and after the granulation to support the granulation. So EGF, here's where it's made, and here's where it goes, and here's what it does. Now, the nice thing about the next one, transforming growth alpha, is that it's very, very similar to EGF. So if you want to say pretty much does the same thing, you can. It's made in the same place, but it's also made in keratinocytes and also made in T cells. But the general effects are similar to EGF. One little exception is that it also works pretty well in hepatocytes to regenerate, to differentiate as well. So think of TGF as the same as EGF, but it also works on liver cells. Okay, now if that's not enough, here's another one called hepatocyte growth factor. Okay, this also works on liver cells. That's why it's called hepatocyte growth factor. It goes to hepatocytes. It's not from them. It's made in mesenchymal cells. And not only does it proliferate hepatocytes, but also proliferates epithelium and endothelium. So if I was to ask you, historically speaking, what do you think we noticed first about hepatocyte growth factor? Is that it proliferated hepatocytes. It was found out to have the same effect on epithelium, endothelium later. Too late to change the name, though. And also, like many other growth factors, in the process of regeneration, you have to actually have cells moving in, so it's another motility agent as well. Here's the biggest player of all. This is going to come up many, many, many times, not only in this lecture, but also in clinical medicine. Vascular endothelial growth factor. This is the big one. It's made in mesenchymal cells of many types, okay? What triggers it to go off? Hypoxia. Isn't that convenient? Because when you have hypoxia in an area, you have to bring in endothelial cells to correct it. So isn't that kind of a homeostatic process? It also increases vascular permeability, and obviously if it is causing the endothelial cells to come in, that means they have to multiply and proliferate to come in. So it's mitogenic for endothelial cells, cause them to multiply or divide. I don't know. This is one place where both terms mean the same thing. So if somebody was to ask you what is the key substance, the key growth factor in promoting granulation tissue, bringing in those endothelial cells, it'd be VEGF. And what triggers it off? Hypoxia. And where is it made? It's made in connective tissue cells or mesenchymal cells. Here's another big one, very similar in many respects to the VEGF, but this one comes from platelets. At first it was discovered it came from platelets. Now we know it comes from a lot of other cells. It's chemotactic for many cells to come in and do their thing. It's also mitogenic for fibroblasts. It's also angiogenic. So it's starting to sound a lot like VEGF. And it's another key player in granulation tissue. So if somebody gave you a list of what are the two top GFs for granulation, you'd have to say VEGF and PDGF. Now, are we neglecting the fibroblast? No. There's a fibroblast growth factor. And by fibroblast growth factor, it doesn't mean it's made by fibroblast. It means it has its primary effect on fibroblasts. It's actually made in many cells. It's chemotactic and mitogenic for fibroblasts. Well, that's logical, isn't it? But we also found out later on that not only does it work on fibroblasts, but also the epithelial cells. And remember the ones that we thought at first worked for epithelial cells, we then found also worked for fibroblasts. So these are not specific for germ cell layers or epithelium versus connective tissue. They actually work on both. It's a key factor in reepithelialization of an ulcer. It's also, like the other two guys before, very important in angiogenesis and wound contraction, also in hematopoiesis. So we talked about EPO, for having a great effect on red cells, and CSF, colony stimulation factor, for having a big effect on white cells. But the GF is also important for hematopoiesis as well. And it also has an effect on cardiac skeletal striated muscle. But just as a curiosity, I'm going to ask you this question again. Do you think that fibroblast growth factor can actually cause a cardiac or striated muscle cell to actually multiply? Okay, you got the right idea. They can't. Okay, so don't ever let anybody tell you they've discovered something which can do that, because it just can't happen. Okay, are we almost done? Yes, we're almost done. Here's another one. And this one affects keratinocytes, and it is made by the connective tissue. Now remember in embryology you heard about the mesenchyme inducing the epithelium? Well, in a way this is kind of what KGF does, because it's made by the underlying connective tissue, but it stimulates the epithelium over them to migrate, to proliferate, and to differentiate. Works at several different levels. One polypeptide, three functions. How do you like that, folks? Insulin, you remember, is kind of acts like a growth hormone in many ways, and there's a growth factor called insulin-like. So if you take the sort of growth properties of insulin, and especially growth hormone, okay, pituitary growth hormone, this growth factor is a lot like it. So it stimulates sulfated proteoglycans for the matrix, collagen, keratinocyte migration, fibroblast production, and it's made by the macrophages and fibroblasts. Okay, well that's just something, that you're just going to have to sort of memorize. I hate that word. What about the first one? What about the important tissue necrosis factor? You know, the first one that was discovered was alpha, TNF alpha. Originally, it was called cachectin because they noticed that people that had cachexia, or wasting away from tumors, had high levels of TNF alpha. And that's because TNF alpha stimulates macrophages, and macrophages chew up tissue, chew up dead tissue, chew up tumors. Sometimes, if you really anger them, you know, like Rodney Dangerfield's quarterback or defensive line, you know, they even go after normal cells sometimes. So it's made by macrophages, mast cells, T cells. It activates macrophages to do what macrophages do, and that's chew up things. And it also has a key influence on other cytokines. So we talked about this being a cytokine. We said not only does it do specific things, but it regulates other cytokines, just like interleukin-1. And of course, the major TNF is TNF alpha. There's a beta too, and someday we might mention it. Interleukins, okay, interleukins are made in macrophages. They can also be regarded to have growth factor properties. They're made in a lot of cells. Their general functions are things we've already been talked about, like chemotaxis, bringing those white cells into where they have to go. Then later on, the ingrowth of new blood vessels, and also as a regulation or regulators of other cytokines. Okay, one more thing, and then we're going to maybe take a break. We'll see. What about the interferons? You know, interferons have been around for a long, long time. When I was in medical school, they were mysteriously odd because of their effect on viral infections. And now we know a lot more about the whole family of interferons. They're made by lymphocytes. You know, we knew that 40 years ago. They're also made by fibroblasts. That was later discovered. It activates macrophages to do their thing, especially doing their things to bad guys, not necessarily good guys. And that's why they were so important. We thought once that interferons would be the cure for the common viral cold. It inhibits fibroblasts, but it regulates other cytokines. Okay, we're done with the bad part of this. We're going to have some fun now. We're going to look at the clock. Oh, we got a good amount of time left. Do I want to ask any questions? Yeah, I'll ask a question. Did you feel a little overwhelmed by this discussion of all of these GFs? Be honest. Well, most of you are saying no. Okay, here's the next question. I know that this is probably not the first time you heard about these GFs. I imagine you had biochemistry and cell biology. Did you have a good feel for them already before, let's say from cell biology or biochemistry? Or I'm hoping this is not the first time you heard of these. I'm getting a mixed response here. I'm getting half yeses, half nos. Okay, good. Let's talk about how these guys work. Remember, we all knew that endocrine substances are things that are made in one part of the body and they're delivered by the bloodstream, perhaps far away. Okay? But most of the signaling that goes on with the growth factors is paracrine. In other words, you have a localized area of inflammation, repair, and they are made by cells which are in very close proximity, perhaps even touching the cells right next door to them to do their effect. So it's not endocrine, it's chiefly paracrine. And in some cases, if you remember, there were some cells or some GFs which we said were made by fibroblasts, and they also work on fibroblasts. Well, that's autocrine. It's a substance produced in the cell, but then it has effect on that cell as well as perhaps others. So those are the three types of signaling. The main type of signaling for growth factors are paracrine. Okay, another thing that I want to, well, here's just the little diagram. There's the perhaps better understood. Paracrine is something that gets produced by one cell and goes nearby to an adjacent target cell. In autocrine, the target cell is itself. So the substance is made, it's released, but it goes back onto receptors on that cell. You know, isn't that really cool? And of course, endocrine, as you know, characteristically goes way downstream, you know, perhaps 6 feet away, rather than just a cell next door. Another thing that I don't want to go into in too much detail to explain, though, how a lot of these growth factors work, is that very often they have a big effect on the cell as a transcription factor. And I believe this diagram was from Robbins. And I'm going to try to tremendously simplify it for you, because a growth factor, I'm going to mostly read this because this is very important. It actually binds to specific DNA sequences. That's what these growth factors do. And then in the process of doing that, they can actually control that transcription process when you're going from DNA to messenger RNA. So think about it. You are actually having a substance that's going to your nucleic acid and changing it to become ultimately a more differentiated cell. So that's one of the ways to understand this very, very mysterious concept, not only in embryology but especially in pathology of tumors, is this concept of differentiation. I'm not going to say anything more, but think of them as often being transcription factors. We cannot neglect the extracellular matrix, the ECM. Remember, we've been talking about cells and products of cells. So the ECM are products of cells. And, we know that the collagens are made by fibroblasts. And, if you would like to think of one or two types of collagens or your basic four, remember, we're up to 18 now. And maybe by the end of this lecture, there'll be 19 discovered. I don't know. Remember the elastic fibers. Remember the fibrillin. These are all the components here within the matrix of the reparative process. If you want to think of your big and growing family of CAMs, or cellular adhesion molecules, causing cells to stick to other cells, like immunoglobulins, cadherins, integrins, selectins. You have to remember proteoglycans, or glycated proteins. They're both proteins and carbohydrates, are a big factor. And of course, the stuff in cartilage and other connective tissue matrix that gives it a bluish hue on microscopy, this hyaluronic acid. So remember that these guys are important too. And what does the extracellular matrix do? What's its role in this whole process? Well, it maintains the scaffold, or the framework, for things to occur, the whole spectacular event to occur, and it establishes a micro environment. And also, a lot of these growth factors that we talk about, they're actually stored in the extracellular matrix, and they're released as needed. And of course, this is where this process of cell differentiation occurs in there as well. Okay, we're going to have a little thing here which I have modified over the years. And here's something that is really nice to remember, because we're going to talk about the big one now, collagen. And I don't know if you ever use this little acronym. I generally don't like memory, mnemonics, and acronyms, but if you remember, collagen 1, or ONE, is the main constituent of bone, which also has ONE. If you think of cartilage, Roman numeral 2, as being in cartilage, okay, that's the major component. That's the cartilage. That's the collagen. That's the major component of cartilage. So patients with genetic cartilage disorders, most likely the collagen that's involved is collagen 2. What about collagen 3? Well, 3 sounds like reticulate. So the major component of reticular fibers is collagen 3. So if you have a fiber that, if you have a disease that involves reticular fibers, and it's genetic or inherited, most likely it's collagen 3 that's being involved. The one I like the best is collagen 4, because it rhymes with floor. So collagen 4 is on the floor. So if you look at the basement membranes, not just of epithelial surfaces, but also things like kidneys, anywhere there's a basement membrane, most likely the predominant collagen is collagen 4. So collagen 4 is on the floor. Collagen 1 is bone. Collagen 2 is in cartilage, and cartilage 3 is reticulate fibers. There is a whole family of diseases. I want you to take a deep breath right now, because we're going to cover a lot of stuff right now in the next 5 minutes. I could go through all these diseases one by one, but I don't think that would be really appropriate, because these are all diseases which I have never myself seen the majority of them, in 30 years of practice, and you'll probably never see them. So let's try to summarize them as much as we can. Do you remember when we said that cartilage 1 was the main cartilage of bone, B-O-N-E, collagen 1? So if you have a bone disease called osteogenitis perfecta, most likely that's going to be something in the some genetic defect which interferes with the proper production of collagen 1. Okay? Now, did you ever hear of an achondrogenic or achondrogenesis, like an achondroplastic dwarf, for example? Their problem is in cartilage, isn't it? So the collagen involved there is probably going to be collagen 2. Now, here's the one that's really screwy. Remember we said 3 were reticulate. Remember, those are very, very elastic fibers, okay? The reticulin fibers. And the classical Ehlers-Danlos syndrome primarily is a genetic acquired inherited defect in cartilage 3. However, look at, there's an ED variant in 1. There's also a 1 in 4. I'm sorry, we said that vascular Ehlers-Danlos was number 3. Classical Ehlers-Danlos is in 5. So those are the top 4, but I think you should also know, I think you should have a familiarity that some of these other weird things which you and I have barely ever heard of and will certainly never see, like Stickler syndrome. I don't know if you're good at memorize it, just remember that's collagen 9. What is Stickler syndrome? Who knows? I Googled it, and it's basically a distinctive facial appearance, eye abnormalities, hearing. So it involves both eyes and ears and joints. It's a whole complex syndrome. But if you hear Stickler, think 9. If you hear Alport, think 4. If you remember, 4 was on the floor. So if I told you that there is a disease of basement membrane of glomeruli, then involving abnormal collagen 4, that's what Alport syndrome is. Another one is called Bethlehem, not Bethlehem, but Bethlehem, and that's collagen 6. And that's kind of a weird one, and I put it down there in the lecture notes. It's progressive myopathies, ankles, fingers, joints. Looks like it's small, basically, joints. That's Bethlehem. So that's a defect of 6. There is a type of skin disease, one of the many bullous types of skin diseases, called dystrophic epidermolysis bullosa. So you know that there's bulla, that there's lysis, of the connections between the keratinocytes, epidermolysis. Dystrophic is probably just an adjective that doesn't mean much, but that's collagen 7. And do you remember how Stickler was 9? Well, epiphyseal dysplasias are very often linked to collagen 9 also. And remember, we talked about losing collagenous connections in skin with dystrophic epidermolysis bullosa, but also in the generalized epidermolysis bullosa. That's now we're up to 17. And because I told you that there were as many as 18 right now, that we actually have a disease of a defect of 18, and that's called Knobloch syndrome, and that's basically an eye disorder. And that's something my son may never see in his entire life, and he is a world-famous ophthalmologist. Okay, the question is now to you all, are you glad I spared you the agony of going into the details of all these diseases? See, I know you're mostly saying yes, but the problem is, there's going to be some little twerp that makes up a step 1 question, and he's never practiced medicine in his life, and he's going to be sitting there on his little throne, and he's going to say, well, I think in order for these students to be good doctors, they're going to have to know about Bethel myopathy, So don't be surprised if some of these come up. We're done with them, though. Just kind of remember this, make a quick thing, maybe connect the Roman numerals to the basic things, or if you want to do that, the night before your exam, I don't care. So once again, we're going to go back to something we've already said 10 times. Regeneration is growth of cells to repress lost tissues. And healing is this whole reparative process we talked about that not only follows inflammation, but in a way it's kind of part of inflammation. It's often called organizing inflammation or granulation. And I think that you should know the difference between the two. Just like we had a saga now, we're going to be getting into the good visual stuff, just like we had a saga with acute inflammation where one thing happening before the other thing, I think you should know that this is the correct order of events in the healing process. First of all, it starts out with inflammation. So you can't have healing unless it starts out in inflammation to begin with. So what happens then? Well, you have proliferation and migration of various connective tissue cells directed by GFs, of which the key player is the endothelial cells. So when the endothelial cells come in, that's called angiogenesis. It's also called neovascularization. It's also called organization. It's also called granulation. So we got 4 names for the same thing, and all it means is influx of endothelial cells. Sometimes I've even heard the word ticking. I can remember making rounds with one of the senior residents, and he goes and he looks at a surgical wound a couple of days after surgery, and he goes, it's ticking very nicely. And I said, well, what's ticking? He goes, well, that's kind of like granulation tissue. I don't know if it's a local word or what, but I bet you I could probably sit down on a good day and talk about 10 different words that have been applied to the ingrowth of new blood vessels after an inflammatory process. Now, collagen does not exactly follow angiogenesis. It occurs when it occurs. It just occurs more. So we could say that as the angiogenesis subsides, the collagen proliferates. Okay, and then we know that the tissue is then remolded. We know with time, and this could be years. It's months, but it often could be years. Your scar gets stronger. There's wound contraction. And usually it's just, let's say, months on the average, but this could be years. And ultimately, there may be some scar there. That's a maximum strength. And I think it's important to just understand the order of this happening, because now when we are going to be looking at a lot of things here, we're going to see the progression from 1, inflammation, to 2, granulation, to 3, fibrosis. Those are the only 3 things we're really talking about today, isn't it? So here's angiogenesis, neovascularization. We know that it occurs from endothelial precursor cells and various growth factors affecting them. We know that the endothelial cells are in blood vessels, so the endothelial cell of one blood vessel differentiates to migrate and extend into your damaged area. We know that of all the many GFs affect us, we put VEGF at the top of the list, but if you go back, you could probably pick out 3 or 4 more. We also know that it's regulated by the extracellular matrix proteins, not just as the area to store the growth factors, but as a very, very big place or a scaffold for angiogenesis or neovascularization to occur. And here are some various names of it. Now, after talking about it ad nauseum, we're going to be looking at it a lot in lab. We're going to look at it here. So here's a tissue. I don't care what it is. It looks like this might be connective tissue. And it's not any special stain. It's just H&E. Some things are red, some things are pink, some things are blue. Look, every time you see a big red area, that's a blood vessel. Some of them are very, very small. those are new blood vessels. Some of them may just be, naked endothelial cells that don't even have a lumen yet. So when you see an area like this, whether it's on a tumor or an inflammatory or a healing process, you know that the presence of all these super red cells, which are red blood cells, for example, are nothing more than granulation, neovascularization, organization, call it what you want. If you call this organizing inflammation, that would be fine. Now, in this trichrome stain on the right, this is not an H&E stain. This is trichrome stain. This is where the collagen stains blue. Up here, the collagen does not stain. You see all the collagen there? So we know that the fibroblasts are the key players here in this third part of the healing process, but there's still a lot of blood vessels too, aren't there? So they're not separate processes. So when I told you we're going to talk about 3 things today, you're actually seeing 2 of those 3 right now. You've already seen acute and chronic inflammation ad nauseum. Well, here's your organizing inflammation, and here's your fibrosis. And probably if you did a trichrome stain here, you'd see some fibroblasts as well, some collagen stained blue, but up here you really see it. What about time? Okay, let's talk about a time interval. We said that there's 3 things: inflammation, organization, and collagen deposition. Well, the inflammatory process can take even as little as, hours, certainly a couple days very often. But assuming there's no complicating factors, the angiogenesis, the reepithelialization, the matrix, the granulation tissue, we're talking about a few days. We're maybe as early as, let's say, 5, but certainly as much as, let's say, a week or 2. You can never give an exact time. I know that in court they always want you to say an exact time, but you can't do this in medicine. And then after, let's say, a week or 2, assuming everything is going okay and the healing process is occurring well, it's getting enough blood supply, which is the main thing, you are then talking about collagen deposition, and at first it's pretty abundant, but then with time, perhaps even years, you have wound contraction now. Wound contraction generally occurs, as you know, following surgery, let's say several weeks, maybe a month at most. So there's your 3 things: inflammation, endothelial proliferation, and maturation. So here's the neutrophil, here's the endothelial cell, and there is the fibroblast, all playing the same big game, aren't they? Here's first intention healing and second intention healing. For some reason, just like with the 4 hypersensitivities, they always talk about primary and secondary intention healing. That doesn't mean a damn thing. In first intention healing, you have little disruption, or perhaps a direct surgical incision in the area. And yeah, sure, you have the organization and fibrosis, but there's basically not much collagen. When you do a clean surgical incision, there's no scar, okay? So when you get to be a surgeon, your reputation is going to depend on how small your scars are. And if you're going to go into plastic surgery, you better make sure you never make scars. In the second intention, there's a lot of gouging and disruption of the matrix, and therefore a lot of new ingrowth of vessels, more than in first intention. And the second intention healing is most likely to produce more fibrosis than first intention. And look at, you already have sort of a pit there. That's not because the collagen is abundant, it's because it contracted. You see? That's called wound contraction. So once again, what's the big thing between first intention and second intention? Number 1, edges are lined up in first intention. And number 2, edges are not lined up. There's a lot more gouging out of the tissue, more granulation, more epithelialization, more fibrosis. Here's our time interval again. And remember, we said that inflammation, granulation, and fibrosis are not separate processes. They often overlap with each other. So look how much overlap there is between inflammation and granulation. That's why this is often called organizing inflammation. But there is a phase in which you have primarily endothelial cells and the necrotic debris and the neutrophils are largely gone. And look, there's even a little bit of an overlap here now between granulation and fibrosis. Remember that slide where we saw a lot of blue collagen? There were still a lot of blood vessels, but generally the granulation is ultimately replaced by collagen accumulation. And look at the time here. Collagen accumulation, generally 30 days. You know, that scar can then last for, 30 years even. But when you are going to be asked how long does acute inflammation last, you're talking a couple of days. When you asked how long does granulation last, you're talking, maybe a week is a good average with a lot of overlap with the inflammation. And then look at the wound contraction is a lot longer. It could start at 3 days and take a month. And that's generally what you would expect when you have a significant injury and you have finally healed and you're healing nicely. That's going to be take as much as a month. You know that. You probably know it from your own body. Okay. Why does this little lesion here have straight lines on it? Can you see the lines? Yeah, I know you need a break. I need a break too. How about if we take a break after this slide? In fact, how about if we take a break now, because I'm getting kind of tired of hearing myself. We'll take a break, show you this nice picture, and then do about 8 cases in lab when we come back. So, the music that we're going to hear during break is all submitted by medical students. The first one is from Irina Nadolska from the Netherlands. She has a very beautiful Polish song. And then we have somebody from Mauritius, Adil is her name, and she's going to give us something from the New Age Yanni. So they're both pretty large songs, so that's why we're all going to play 2 this time. See you in about 10 minutes, folks.
Jak obłowaty na patyku, który się chce pogłaskać ręką. Ta nasza radość, że nie znika, uśmiech w piosence dla Helenki. Kiedy wsłuchuję się o świcie, twój oddech, co jak kołdra miękki. Czuję, że życie znaczy życie, razem z piosenką dla Helenki. Się wsłuchuję, o miłości moja, i cały świat znajduje, o miłości moja. Poduszka palce pleści, a szczęście ma zapach, zapach ma czereści. Ktoś obcy być przestaje obcy, bez kogoś naraz jak bez ręki. W dorosłych się zmieniają chłopcy, nucąc piosenkę dla Helenki. Kiedy brakuje jak powietrza kogoś, z kim można iść pod rękę, to z każdym krokiem coraz lepszy miłosny duet dla Helenki. Wsłuchuję, o miłości moja, i cały świat znajduje, o miłości moja. Poduszka palce pieści, a szczęście ma zapach, zapach ma czereści. też od siebie z dala żyły krawaty moje twe sukienki. Naraz się w jedno połączyły w cukrowym sercu dla Helenki. Miłość się wreszcie stała ciałem, które chcę trzymać nas za rękę i które znam na pamięć całą słodką piosenkę dla Helenki. Dla Helenki.
was great music. The first one was from Netherlands, from somebody that understands Polish. It was a Polish song of, I think, I translated it in Google Translate. It's basically a song of a man singing a nice little song to his small girl named Helinka. The next song was by Yanni, big new age guy. Beautiful music also. I generally don't like to play elevator music here. Yanni is not elevator music. That was a beautiful song, but I generally like to play music that has a beat. And I wanted to remind everybody that all student music will be played. I already have a big collection. I may not be able to play it right away. I may play it, 2 or 3 months after you send it, but it will all be played, I promise you. Very often, the only time I could really think is when I have this 10-minute break period. I discovered that I can't open my mouth and think at the same time. I have to do one or the other. So when I'm finally taking a break and shutting my mouth and taking out the dog and making another cup of coffee and recycling my coffee is when I could think about what I wanted to say. And the only announcement I have is that we've been having a good time here, and we have been covering approximately 1 chapter per day. These are short chapters, folks. The first few chapters are short. They're often not extremely clinical. And from here on in, it's probably going to take us an average of 2 or sometimes even 3 days to cover a chapter. When we get to the huge chapters like GI, it may take us a week. There's only a few chapters left that I could probably do in 1 day, like maybe ENT or pancreas or something like that. But we're actually going to be getting a lot more clinical and a lot more detailed. I see that, let's see. Oh, I see. There's a lot of questions, and I know Dr. Kamat is here. So I'm going to assume he answered those questions. And the reason I knew I could stress you out in the first half and go over the hours because the lab is not going to be very big. If you remember, we only had about 8 cases, and they are all going to be demonstrating the stuff that we talked about. And we're going to see that this whole concept of inflammation, granulation, fibrosis doesn't just occur in injured areas. It occurs as parts of many processes. It could occur inside of a blood vessel in a thrombus. It could occur in the heart as a heart attack. It could occur just about anywhere. So a lot of these cases we'll see now are places in which these processes take place. And I think they're all extremely logical based on what we have just talked about. Here is a tissue, a slide, a real slide. Remember, we're in lab now. I love this slide because not only can you see the disease, but you can see what probably caused it. Here, let's make things simple. Let's go back to the real cells in question and forget about, you probably already know the diagnosis, but here, take a look at this. What kind of cells are these? That should be slam dunk, easy recognition. And I can see you all know that this is cardiac muscle. Yeah, cardiac myocytes. Looks pretty normal here, doesn't it? Well, that's because I was in the normal, healthy part. What if I was to ask you, if this was the normal, healthy part, what do you think these white areas are over here? Let's blow it up and help you answer your question. Well, yeah, we got sort of normal cells here in the northeast and perhaps along the east coast, but this whole western and southern portion, they're not normal cells. The cells are gone. They're being replaced. You see a lot of blood vessels, don't you? There's a blood vessel, there's a blood vessel, there's a blood vessel. Look at, you even have some pigment in cells. These are probably blood that's been chewed up, or hemosiderin that's been chewed up by macrophages within this destructive inflamed process. But you don't see too many neutrophils here, do you? You see mostly endothelial cells. In fact, some of these cells here, for example, this cell, This could very well be an endothelial cell. It just hasn't decided to form a lumen yet. It could still be in the process of migrating under those various growth factors. I would also like to remind you, if you remember from our diagram, that even fibroblasts can come in as early as 3 or 4 days. Some of these cells, that might even be a fibroblast. There's just not a lot of them. Now, what's this white stuff? Could some of it be blood vessels? Could some of it perhaps just be fat that's occurred because of the inflammatory process? Well, this is the stage of an infarct that's called recent. It's not acute. If it was acute, we'd have nothing but neutrophils, okay? And perhaps dead pycnotic, karyolytic nuclei before we see the neutrophils. You don't see too many neutrophils here, do you? This looks like it might be a plasma cell or a lymphocyte. Here's a couple of macrophages. You know that because they have pigment in them. But I know something? I don't really see one single thing I would call definitely a neutrophil. Neutrophils are gone. This is not an acute infarct. This is a recent infarct. And recent means there's some organization going on. There's some cleaning up of dead stuff. But there's not much fibrosis either. What if I showed you this picture and I said, is this an acute, a recent, or a healed or remote myocardial infarct? Which one would you choose? Yeah, recent, rather recent. Now, if we moved on and saw some areas that had scar tissue, I don't know, maybe we can probably find an area like this that maybe has more fibroblasts. It could still be recent because it doesn't look like it's solid scar yet. No, it's pretty much the same thing, isn't it? There's parts of perhaps a dead or maybe even partly normal cardiac muscle fibers at the top. This is called recent infarct. And here's a nice blood vessel. Here's a small blood vessel. The thing you have to remember is that, I know what I wanted to show you here. Take a look at this. Let's say that you're real smart and you say, well, I know why there's an infarct here. This big coronary vessel looks thrombosed. Look how thick the wall is. Look how narrow the lumen is. Maybe there's even a blood clot there. I don't know. But it would all make sense that if this was infarcted, it might be infarcted. And this is a huge artery, folks. This artery is so huge, it would be something that you would have had to learn the name of. This could be a LAD, it's so huge, or a circumflex. This is a major artery. It's not a small one like that. The thing I wanted to point out here is not only does this process of organization and fibrosis go on in the damaged tissue, look, it's going on inside of the blood vessel lumen here too. What do you think these little vessels are? Here and here and here. This is organization too, isn't it? So can I suggest that not only is this a recent infarct, but this is an organizing thrombus as well. If all you saw were just nothing but red cells, you might say, well, that's just blood that's in the vessel. No, look, there's fibrin. There's ingrowth of new blood vessels into the clot. This is an organizing thrombus, and it is a recent infarct. How do you like that? Yeah, neovascularization. And by the way, you see all these little slits here and here, these little needle-shaped slits further down within the plaque? What substance would that have been if we didn't wash it out with xylene? Yeah, those are your cholesterol clefts. Okay, but we're not going to go into heart today. We're going to do that on another day. Let's go into another organ here. Slide number 2. And I'm assuming it's going to pop open pretty soon. If not, I'll click it again. First question is, probably a lot of you are not even recognizing this as lung because you don't see any air spaces. So you're saying, oh hell, this can't be lung. But look, let's zoom in on an area where it's less densely infiltrated, like here in the northwest. Could you see the alveoli now? So you know this is lung, right? But you know most of the alveoli are filled with some kind of cell. And there's still a lot of inflammatory process going on here. But here's the question. Take a close look at these alveoli. I'm going to zoom up on you. Do you think that these are primarily neutrophils filling up the alveoli? Yeah, there's thickened alveolar walls, there's fibrous tissue, but look these are not neutrophils, are they? I'm having a hard time finding some classical neutrophils. I mean, I'm sure I could find one or two. These are basically macrophages. But take a look at the fact that there's some fibrosis coming in here. So let's say you didn't want to get fancy and you just wanted to call this pneumonia. Would you call it acute pneumonia? Or would you call it organizing pneumonia? Yeah, it's organizing. Now, I really don't want to use the word chronic pneumonia because that opens up a new door to a whole different family of diseases. We'll say this is a pneumonia. You know that because there's infiltration of some kind of inflammatory cell, and they're not really neutrophil. I guess if you wanted to call it chronic pneumonia, generically you could. But let me ask you this. What are almost all of these little spindly cells here, what I'm pointing to? These are fibroblasts, aren't you? And if you did a trichrome stain, the substance between these fibroblasts would be very blue. This is collagen. So you can see there's already some collagen deposition. Now you know that in most cases of pneumonia, the resolution is 100%. So I do not suspect that these fibroblasts are going to be there forever. I believe eventually, usually the cases with acute bacterial pneumonias, if there's resolution, this whole thing will return back to normal with no cells inside of the alveoli and very, very thin septae. Like they'll all be as thin and nice and normal as that. And look at, there's one capillary within that septum there. Okay, we're done with that case, unless somebody else wants to say something. We're already up to the third case. And I think you'll recognize this very quickly as being what organ or tissue? A lot of air spaces here. Yeah, you all say lung. And there seem to be like pretty much hyper-expanded air spaces near the thickened fibrous pleura here. And I don't want to get into the classification of fancy things now like interstitial lung diseases or anything, because that opens up a whole new door. But we want to get things down basic. We're only in our third week of pathology. I just want to ask you a few simple questions here. I zoomed in on the middle, and here's the first question. Are there a lot of cells infiltrating the alveoli? Yes or no? Okay, you all got the right answer. Second question is, are some alveoli or air spaces looking pretty big, bigger than they should be? Maybe emphysematous, if you don't mind me using that word. Yeah. Now, even though we described two changes here, let me ask you the key question. What is the main pathologic problem here in this lung? Well, I'll give you three choices. Neutrophils in the alveoli, emphysema, or thickened fibrous septae. What's the answer? Yeah, it's thickened septae. So there's fibrosis going on here. Now, in this type of lung disease, unfortunately, this is not the kind of thing that's going to go away like a resolution. This is an interstitial lung disease. It has a variety of causes, of which occupational or pneumoconioses are just one small portion. But this is also a very, very severely, irreversibly damaged lung. And the process here is fibrosis of the septum. So if you have thick fibrous septa, you're probably not oxygenating these alveoli very well, are you? Okay, well, that's the problem. Fibrosis. Of the three things we learned about today, inflammation, organization, fibrosis, what is the key thing we're seeing here? Fibrosis. Good. Let's move on to our next case. Aha, you're going to love this one. And this is what we see over and over and over and over again. We talk about tumors, we talk about inflammation, we talk about degeneration. But remember, the inflammatory process in the inflammatory spectrum, from inflammation to organization to fibrosis, it also occurs in other areas other than normal tissues. We saw it occur inside of a thrombus, which was inside of a blood vessel. Now, I think you'll recognize this tissue right away, because you can all see at the periphery here, there's something that you'll recognize instantly. So you know what organ this is, right? And you know that the majority of this thing that we're looking at, that's compressing or occupying most of this lung, or at least the portion we sampled, is a big, hyalinized, pink, and sometimes pigmented with anthracosis nodule. And if you did a trichrome stain of this, what color would this pink turn into? Yeah, why? Because it's 100% collagen, isn't it? Or mostly collagen. There's a few trapped macrophages here that look like they have some pigment. You want to prove it? Yeah, let's prove it. Yeah, there's some anthracosis, but this is all fibrosis. And there's very, very little by way of fibroblasts here. It's almost all collagen, isn't it? So, what we have here is a former granuloma. I know we haven't talked too much about granulomas yet, but we've defined them. And we said normally they're composed of macrophages and giant cells. And this one is all hyalinized or fibrosed on the inside. So what kind of granuloma is this? Is this an acute granuloma, an organizing granuloma, or what we call an old or healed, fibrosed or hyalinized granuloma? Yeah, see, the disease process of granulomas also have the inflammatory changes as well. So let me ask you this. If you found this granuloma in a lung of a guy that you're doing an autopsy on, and you go, oh, granuloma's in the lung. Let's culture it. Let's see if TB or fungi can grow out of it. What's your likelihood of growing acid-fast bacilli or TB or fungi out of this old, scarred, hyalinized, healed granuloma? Yeah, very, very low. And by the way, do you remember I told you that the main component of granulomas are giant cells and macrophages, but sometimes they have fibroblasts on the outside? Well, the more years, months and years this process goes on, the more of these fibroblasts will eventually replace the whole granuloma. Do you also remember I told you that often there are a few lymphocytes on the outside of the granuloma too? Well, look, what are all these cells in here? We still have a few lymphocytes scattered at the interface between the viable lung and the granuloma. Last question, also an important general pathology question, is this. Is this granuloma very well defined from the surrounding lung, or does it totally yeah, okay, you already got the answer. I didn't even have to finish the sentence. So this was called healed, hyalinized, fibrotic, whatever you want to call it, old granuloma, not likely to culture whatever organism may have caused it. So let's go on. And looks like this one, oh, this is an interesting one too. We're going to discuss all phases of healing here. What if I was to just tell you this was from the oral cavity? It doesn't matter, but this is where they're usually found. Let's say it doesn't matter where I got it from. Let's say I was just going to blow up this part for you, which we're going to take the top piece of tissue, make a little box, and I was to ask you, what if I told you this was a heart? What if I told you this was a liver? What if I told you this was a thrombus? What if I told you this was a granuloma? It doesn't matter what I told you it is. What you are seeing here is the granulation process, aren't you? You're seeing a connective tissue framework, you're seeing some residual inflammatory cells, and you're seeing an abundant ingrowth of blood vessels. So, if you saw this as a question for a classical granulation tissue, you would say, that's it. It doesn't matter where it is. This is granulation tissue. And by the way, let's look at some of these cells. Can I ask you, what are most of these cells? Yeah, it's angiogenesis. Yeah, most of you know that these are polys, right? Because you can see the multiple lobes. There's one, there's one, there's one. These are all polys or neutrophils. So saying, well, this looks like the phase of inflammation where maybe the polys haven't gone away yet, but a lot of the blood vessels are coming in. This is probably the early stage. Well, the reason why I'm showing you this is because this tissue, which I'm showing you, no matter where I show it to you, which be called clearly granulation tissue. And by the way, if I showed you any part of this tissue, or I showed any of my brilliant, Nobel Prize pathologists this tissue, they would say granulation tissue, granulation tissue, granulation tissue. And then if I said, well, it came out of the oral cavity and it's been there for a while and it looked like a tumor, well, then they would call it a pyogenic granuloma, because that's what this case is. It's a pyogenic granuloma. Now, if you think I'm trying to confuse you, I promise you I'm not trying to confuse you. But what I want to say is this pyogenic granuloma is a double misnomer. Number one, it's not a granuloma at all. And number two, it's not pyogenic, other than the fact that there's a few neutrophils left in this organizing inflammatory process. If they would call this granulation tissue rather than pyogenic granuloma, the double misnomer, then that would be more appropriate, wouldn't it? So here's the final question. All I want is a yes or no. Is a pyogenic granuloma exactly the same histologically as normal healthy granulation tissue? Okay, next question. Is a pyogenic granuloma a granuloma? Last question. Is a pyogenic granuloma pyogenic? Okay, so now you're learning a lot more about medicine. Medicine is just loaded with wrong words, and at least we understand the processes correctly, but we have to live with the wrong words. Let's go to one of the last few cases now. Yeah, we're down up here. Okay, folks, boys and girls, you see this? All these little spaces here. What is this? What organ is this? Okay, you all know it's lung instantly. And let's say that the upper part here, you can still see a bronchus, but you can see that this part of lung looks like it's just loaded with acute inflammatory cells. So here, let's do a northeast capture. And we got some relatively normal alveoli down here. We could see the epithelium of a bronchiole here. And I'm calling it a bronchiole because I don't see cartilage. We got a blood vessel here. We got most of these alveoli up here filled with inflammatory cells. And, oh, not really. It looks like there's some organization going on. There's still some inflammatory cells here. Let's say that I told you this process was generally, at some point in time, a pneumonia. You'd probably believe me. But do you remember there's a stage in the inflammatory process called fibrosis? Now, what is normally at the periphery of the lung? A little membrane called mesothelium, also called a pleura. And this inflammatory process has not only extended to the pleura, and not only has caused fibrosis of the pleura, but it has also caused the pleura to be adherent to this tissue down here. And I know you're going to recognize this tissue right away down here. What is this tissue? Come on, I know you got it. Yeah, this is skeletal muscle. I think if I blew it up, you could even see some striations. So we got an inflammatory process in the lung causing fibrosis and granulation and even extending to the pleura, but also causing the pleura to adhere to the skeletal muscle of the intercostal. So we got the inflammatory fibrotic process extending from the lung to the visceral pleura, to the parietal pleura, and all the way to the muscle. And by the way, I am going to blow this up because I know a few of you still don't believe this is skeletal muscle. So I'm going to prove to you it's skeletal muscle. We're going to find some striations. Hey, you see these little lines? Those are striations. Look at how the nuclei are at the periphery of the fiber. So Fibrosis could be a destructive process. In this case, it's interfering with proper movement and ventilation of this lung. Yeah, could it even cause vertebral adhesions? You're darn tootin' it can. We've seen that it's already gone all the way to the muscle. That would be extreme. So we're learning more about this process we talked about all day. Here's another really good one. We've seen an example of this before. I'm going to show you a nice piece of tissue here. And I'm assuming it's going to open up for me. And you know that there's a lot of glands down here, right? You know these are all glands. Look, there's even some secretion material in these glands. Would somebody like to make a stab of what gland this might be? You know, all you know it's a gland. Yeah, I got somebody, the first three guesses were prostates, and by the way, you're all right. But look, there's also some big blood vessels in proximity to this prostate, perhaps part of the prostatic venous plexus. Remember that? And we're going to blow up on some of these blood vessels, like here. We'll take this big one, for example, maybe part of the other one. Do you think that this is only blood that happens to be filling this prostate when we cut it? Or does it look like it has texture to it? Do you see some fibroblast? Do you see some fibrin? This is not just a big old blood clot that happened to form. This is a thrombus. Okay? Now, a thrombus can go through all of those phases that we talked about. A thrombus can heal with blood vessels. It can also become fibrotic. So, the question is, if I told you this thrombus was an organizing thrombus, what would be the main component of it histologically? Fibrin, blood vessels, or collagen? Yeah. Most of you are saying blood vessels, but some of you got wrong answers. So anything that's organizing, remember, blood vessels, granulation, angiogenesis, neogenesis, that's the main thing. In this one, there's fibrin, but there's also, I would bet that a lot of these cells here are ingrowth of blood vessels, okay? I think that many of these cells are endothelial cells. You could actually see some blood cells within them. But what if this thrombus was primarily collagen? What would you call it then? Acute, organizing, or healed thrombus? Yeah, you got the picture. Good, I'm glad everybody's picking this up. I think we have one more here. And by the way, we do have a couple minutes at the end. This is something really wild I'm going to throw at you over here. Because we talked about the effects of fibrosis. They're not always that nice. What if you had a tubular structure here that looks like it has some type of mucosa? It looks almost like a papillary mucosa. There's some smooth muscle in the wall. Let's say you don't exactly know what it is. But let's say it's big and it has kind of a papillary mucosa. And let's say that there was some previously existing inflammation in that structure. And let's say that the inflammation then led to neovascularization. And then the inflammation led to fibrosis. And let's say that the fibrosis obstructed the migration of the fertilized embryo, the fertilized ovum. Okay? So look these are placental villi over here. And this is the mucosa of a dilated, perhaps the ampullary portion of the fallopian tube. But maybe this is not an ampullary portion. Maybe this is just a portion that was dilated because it's filled with this thing here in the southwest. For those of you who have taken embryology, I don't think you'll have any problem recognizing this as being part of an embryo. It has that bluish mesenchyme. It has what looks like might be a neural tube. Just out of curiosity, I want everybody to answer this question, yes or no, even if it's a no. Have you all taken embryology? I'm seeing predominantly yeses. I see a couple of no's there. But it's important that if you haven't taken it, that you also answer the question as well. So good, that means I'm dealing with medical students, and that's what I like to see. Okay, so we're done with that portion, and that is the last lab case for the day. which means, oh, I could open up the audience box. We still have over 100 here today. I'm very happy that we have so many people. I wanted to show you this as well. See this little map here? This is you. We have, when we started this course, we had 500 students. Now we're pushing 1,000. We have 860. I looked at our attendance enrollee registration list. We have 95 countries represented. The USA has got about 150. Believe it or not, India is right behind us. There are only a couple less in India than in the United States. We have almost 100 in Pakistan. And the thing that really blows me away is that number 4 on the list, you know, probably 60 students strong, is Egypt. So I want to pay a special tribute to our Egyptian students as well. I don't know what it is about Egypt, but they must certainly value education very highly in that country. I'm very proud of Egypt. I hope to go there someday. Dr. Zayden will be visiting me in a couple of weeks to learn this process. He's a famous pharmacology professor. He's from Egypt too. I'm going to ask him why there's so many smart people in Egypt. Okay, we're ready for our final song. And we're done with our lab. And I want to say that this final song is also very inspirational. It's by a woman that blew away Britain's Got Talent. Her name was Susan Boyle. It's from the famous book Les Miserables, also a play that's very popular as well. And nobody can do this song better than Susan Boyle, and that's why she won the competition that year for Britain's Got Talent. See you in 5 days, folks, and I can promise you that our sound will work perfectly for the rest of the year.
I dreamed a dream in time gone by. With hope is high and life worth living. I dreamed that love would never die. I prayed that God would be forgiving. When I was young and unafraid, and dreams were made and used, I stayed. There was no ransom to be paid, no song unsung, no wine untasted. But the tigers come at night, with their voices soft as thunder, as they tear your hopes apart, and they turn your name to shame.
Rock on, you buzzards.